Awesome. Hi, I'm Rebecca and I'm a registered nurse in the emergency department at Middlemore Hospital. My presentation today is about screening for sepsis in our department. So a quick background for any non-clinicians in the audience. Sepsis is a life-threatening response to an infection in the body. There have been a couple of conferences defining sepsis so that there's sort of a consensus for research and in clinical practice, and the first two focused on, as you can see in this diagram here, in the way sepsis related to the SIRS criteria, which is a systemic inflammatory response in the body, and that SIRS criteria is on the slide there. And then just last year there was another consensus conference which updated the definitions, looking at what we know more about sepsis now, with the aim that those updated definitions could be used for consistency in research and also facilitate early diagnosis and treatment. So what do we know about sepsis in our ED? We've been auditing sepsis for 5 years after a HDC incident with a poor outcome, and we've found that there's two cohorts of patients in our department. The first cohort, they present quite unwell and they're identified early at triage. They're prioritised to have urgent care in a high acuity area, and we know that about 80% of these patients receive antibiotics within an hour. And the second cohort are not so easily identified. They maybe look a bit more well when they come in, and only 16% of these receive antibiotics within an hour. So at the time that we started auditing, we were focused, so these two cohorts come from patients who go on to need ICU care for sepsis, and we chose 1 hour as the target, which was in line with the best evidence and research at that time. We've done a bit more analysis on that second group of patients to see why they have delayed treatment. And there's a lot of reasons for this, but particularly they're not identified early, and their presenting complaint can be a lot more vague. They might be coming in with a fall or confusion, back pain, abdo pain, not necessarily an infection. There's also overrepresentation for Maori and Pacific Island people in this group. So we've developed a screening process in our department which was initially based on those earlier definitions in relation to the SIRS criteria, and we modified it for our population. There's 6 criteria, and if you met 2 or more, your care was escalated into a sepsis pathway. So we know that this is still not identifying the right patients in that second cohort because we're not reaching the target we'd like to. And in particular, we did a pilot study last year which showed that this criteria, or the screening tool, didn't have the right sensitivity and specificity to pick up the patients we were looking for. So at the same time we were looking into our group, our department, the 3rd International Consensus definitions were published for sepsis and septic shock, and as part of that they published a screening tool called QuickSOFA, which they suggested could identify patients with sepsis outside a critical care setting. So this is the QuickSOFA tool. It's modified off the sepsis organ failure assessment tool, which is commonly used in ICUs to identify patients with sepsis who have a poor outcome or high mortality. And this is an abbreviated sort of version of that which can be easily assessed at the bedside. It doesn't require any lab work or radiology, and it's made up of, you get 1 point for a low blood pressure, 1 for altered mental status, and 1 for a high respiratory rate. And a score of more than 2 indicates a high chance of deterioration. So our research question was, how sensitive is the SIRS criteria compared to QuickSOFA at identifying patients with sepsis in our population? We wanted to prospectively validate the QuickSOFA score because it had been designed based on retrospective data. And so we did this just in our department. We looked at 556 patients who came in with a possible infection as their presenting complaint. And then we followed them through their hospital stay and excluded any patients who turned out not to have an infection. We looked at routinely collected data and applied these 2 criteria to their initial presentation, and then our primary outcome was which of these patients went on to have sepsis with organ failure who required ICU input. We also collected data on length of stay in ICU and in the hospital and mortality. So our results showed that the quick SOFA score actually had a really strong positive predictive power compared to the SIRS criteria, and also had an acceptable negative predictive power. So I guess the patients that we're identifying were more likely to be within that second cohort that we were looking to provide better care, more timely care to. In particular, that higher specificity is really valuable to our department because we experience high patient volumes and we want to be directing our resources to the right patients. So our plan with these results are to go on to phase 2 of our study to use this new criteria to develop a rapid response pathway for sepsis. And our aim is that patients who meet quick SOFA criteria will get an early review by senior staff and early decisions about antibiotics and general sepsis best evidence care. And our primary outcome will be still measuring time to antibiotics and also looking at those secondary outcomes of hospital length of stay and mortality as well. And that is my presentation. So I rushed through it. Are there any questions from anybody?